let's start with the assessment of coronary artery disease. Shown on the left side of this slide is a pathologic specimen of an atherosclerotic coronary artery originating in the sinus of Valsalva from the aorta. It transmits blood flow through the epicardial vessel down into branches of lower resistance, into the myocardium, and then into the intramyocardial capillaries. These levels of resistance contribute to limited blood flow. The only one which we can really treat mechanically is that of the epicardial or R1 resistance atherosclerotic buildup, which you can see in the middle of this artery. And with that, we'll be able to determine perhaps the physiology of that stenosis to make the best decisions for outcome. So let's just look at the anatomic evaluation of coronary artery disease before moving to functional assessment. In this middle section, we see the panel divided into the top invasive method and on the lower panel the non-invasive methods. Returning to the top, we see the most common tried and true way of looking and determining if atherosclerotic coronary artery disease is present, and that is the angiogram with the narrowing of the lumen. Unfortunately, that lumen does not provide enough information for us in many cases, and we have advanced our knowledge base through the use of intravascular ultrasound imaging, the small gray and white image in the corner on the left, and through intravascular optical coherence tomography imaging, the smaller insert on the right. These give us anatomic information of lumen size, wall composition, and surrounding features, but again are limited in looking at whether flow through such a vessel is normal or abnormal. On the bottom panel, under the non-invasive anatomic evaluation section, we see a CTA with 3D reconstruction. We see a number of different presentation formats, and again, providing us with more information about coronary artery disease, this time beyond angiography, in providing some information about the plaque and its composition. Moving from anatomy, we enter the functional testing or physiologic testing area. And on the bottom first, with the non-invasive imaging to the left, we see functional testing to the right, and I put stress testing. Every day in every lab around the world, if you want to know whether somebody may have coronary artery disease or myocardial ischemia, you would perform a stress test of your kind. They are pretty accurate, but not great. 80% to 85% true positives leaves some questions in many patients. I'll return to the far lower right panel of a CTA with FFR, which is the most recent combination of imaging and functional assessment. Let's turn our attention to the top right panel, where we have diagrams of the fractional flow reserve measuring pressure through the guide catheter and across the stenosis using a pressure wire. We create a ratio of the distal to aortic pressure, and we measure it at hyperemia when resistance is minimal and fixed, and we determine the percentage of normal flow through that stenosis. Please recall that the pressure is transmitted in a coronary artery completely normally without any pressure loss in the absence of atherosclerosis. Thus, the ratio of pressure from distal to proximal, or from the coronary artery to the aorta, should be 1 if there are no obstructions. Thus, we can determine, based on some simple principles, that the loss of pressure across the stenosis reflects the loss of flow due to the increasing resistance. We'll talk more about that in just a moment. On the far upper right panel, we see a diagram of the coronary artery and 2 tracings, the proximal and distal pressure tracings, with a wave-free period, the WFP. This is a particular interval during rest where the resting flow in diastole is high and the resistance is fixed and thought to be low. This resting ratio is called the instantaneous wave-free ratio when there are no further reflected waves moving through the heart, and the ratio of the resting aortic to distal pressure creates a number similar and approximates the FFR, a value which we ultimately know will be identified with myocardial ischemia. We'll again get into more detail in just a moment.